So we get started. So the topic for today's grand rounds is health span, a call for metabolic combat. So I have no disclosures. The objectives, we're going to talk about insulin resistance, touch upon circadian disruption, some brief slides on brown adipose tissue, and then again talk about time-restricted feeding. So what is the health span? So the Oxford Dictionary defines it as the part of a person's life in which they're generally in good health. So the Webster says, a period that's healthy and not just alive. Dictionary.com, generally healthy and free from disease. So you get the general gist. To put it in a pictorial, so over the decades, we've definitely increased lifespan. So this is birth and this is death. But as we've increased lifespan, we've also increased the duration of morbidity. For example, everything that goes with aging, cardiometabolic disease and so on. And this would be the ideal scenario where you have a longer lifespan, but you've reduced your duration of morbidity or disease, and you live longer, being more healthy and physically active. So if you want to talk about lifespan, we have to start at the very beginning. So how does the first 9 months of life, really shape the rest of your life? And to understand that, we have to understand the thrifty phenotype hypothesis. So, at the very outset, birth weight can be a predictor of cardiometabolic disease later on in life. And that includes, both extremes as far as, being low birth weight as well as macrosomia or large for gestational age. It's a U-shaped relationship. So there are interactions between the gene and the intrauterine environment that influence the risk of disease. For example, if you have your beta cells being affected, you could have reduced beta cell mass, a predisposition to diabetes. If you have effects at the level of the liver, the skeletal muscle, you could be at risk of developing insulin resistance. If you have, your hypothalamic pituitary axis being affected, the centers that control appetite, you might be at risk of obesity. And if you have your kidney being affected, again, you're at risk of hypertension and so on. So these are the interactions between the genome as well as the environment that's created in the intrauterine milieu. So to understand, the role of placenta, which plays a critical role if you're talking about the risk of metabolic disease later on in life, but more so acutely the risk of, being extremely low birth weight or large for gestational age. So if there is a state of maternal undernutrition, you have downregulation of insulin and IGF-1, and there is decreased availability of nutrients to the fetus. Now, when all this happens, you have downregulation of a key sensor in each of the cells called mTOR, which downregulates growth. Now, in the setting of maternal overnutrition, you have upregulation of insulin, upregulation of IGF-1, and you have increased availability of nutrients to the fetus. And in the process, upregulating mTOR and larger growth, which leads to a large for gestational age baby. So to understand, chronic disease and metabolic disease, we have to talk about the mitochondria, because most chronic diseases really, happen in the background of mitochondrial dysfunction. So the master regulator of mitochondrial biogenesis is this cofactor called PGC1 alpha, which is PPAR gamma coactivator 1 alpha. And the term mitochondrial biogenesis means the formation of new and healthy mitochondria. And that means, better energy metabolism, better energy expenditure, and so on. Now, how does this play a role into nutrition or nutritional states? So here is PGC1 alpha, which upregulates mitochondrial biogenesis, which means you have the formation of new and healthy mitochondria. And here is, let's introduce a few other concepts. So autophagy and mitophagy. So what is autophagy? So Autophagy is essentially cellular recycling. At the subcellular level, what you're doing is you're getting rid of your older senescent components and replacing them with newer, more healthier components. And what is senescence? Senescence is aging, but also you can look at it in terms of continued growth in the absence of repair is what aging essentially is. So in the setting of caloric excess, you have downregulation of PGC1 alpha and then decreased mitochondrial biogenesis. So that might put somebody at risk of developing chronic metabolic disease. But if you have states of energy deprivation that go along with the states of nutrition, then you have upregulation of PGC1 alpha. And again, having mitochondrial biogenesis, but at the same time leading to autophagy. So you're getting rid of your older components and facilitating recycling and rejuvenation and so on. So another key component here is this target of rapamycin, which is mammalian target of rapamycin. You might have heard about drugs that work on this pathway, everolimus and so on, used in transplant. And in clinical studies, they've been shown to increase survival and reduce the risk of cancer and so on. And the mechanisms in which they do that are again coming down to these key mechanisms here. One, you're getting rid of your older components and facilitating newer components, at the same time delaying excessive growth and proliferation. So how does maternal diabetes and obesity influence what happens in the fetus starting early on? So this is looking at 1-month-old infants. This is indirect calorimetry to look at energy expenditure. And you find that when you look at infants of mothers with diabetes, and this is the group we're talking about, and look at energy expenditure, their energy expenditure is lower than infants of mothers without diabetes. Okay? And when you look at substrate oxidation as to what's causing or what's driving that lower energy expenditure, you find that it's a decrease in fat oxidation. And carbohydrate oxidation between the two groups remains the same. So clearly at a very young age, if you're an infant of mother with diabetes, you have a hit in terms of energy expenditure. And there are multiple studies to show that even later on in life, both in early childhood and adulthood, if you have a family history of diabetes, you have lower energy expenditure and so on. So again, coming back to PGC1 alpha, remember this is the cofactor that contributes to mitochondrial biogenesis, healthier and more functional mitochondria. So when you do skeletal muscle biopsies in the second and third decade, offspring of women with gestational diabetes mellitus, you find that there's a decreased expression of PGC1 alpha in the skeletal muscle. This is offspring of gestational diabetes mellitus compared to type 1 diabetes and background population. So could this be the reason for higher risk of diabetes and obesity later on in life in these infants? So if you look at insulin sensitivity and insulin action, we know that if you're born to a mother with obesity or diabetes, you're at a higher risk of one, large for gestational age at birth, but a higher risk of obesity and diabetes and metabolic disease later on in life. What are the underlying mechanisms? We talked about mitochondrial biogenesis and PGC1 alpha, but if you're looking at the insulin production and insulin action, you find that in the offspring that were born to gestational diabetes mothers and also in offspring that were born to type 1 diabetes mothers, you have a reduced insulin production, but at the same time also predominantly a reduced insulin action. So talking about insulin resistance, even before they were long before they were diagnosed with diabetes. So what about the role of the gut microbiome? This is an emerging topic and we're learning more and more. But clearly, one, if you have an altered gut microbiome, you're at a high risk of cardiometabolic disease and cancer and inflammatory disorders and so on. But it seems to start very early in life, even from the maternal gut microbiome and so on. such that that could put the baby at the risk of having altered gut flora. And other factors that might play a role are breastfeeding, which has a favorable effect, vaginal delivery, again a favorable effect, as opposed to C-sections, which might increase the risk of obesity, maybe through altered gut flora. And again, the role of antibiotics, excessive exposure to antibiotics or exposure to antibiotics could lead to an altered gut flora and put somebody at a risk of metabolic disease later on in life. In fact, just a single course of ciprofloxacin for 5 days, it apparently takes about 6 months for the gut flora to recover its normal number and diversity. So what about the benefits of breastfeeding? Beyond everything else that we know, this is looking at adequate breastfeeding versus inadequate breastfeeding. So adequate breastfeeding in this study was defined as a breastfeeding duration longer than 6 months, compared to the control, which is of breastfeeding duration of less than 6 months, and monitoring the weight over time and BMI over time of these infants. This is the first 30 months of life, and they are followed up to the age of 14. You find that with adequate breastfeeding, both in mothers with diabetes and mothers without diabetes, you have a similar benefit in terms of a lower BMI in the infants, but also a lower growth trajectory. So we talked about mothers with gestational diabetes mellitus. There's a higher risk of adverse outcomes to the neonate, but also to the mother in terms of a higher risk of gestational diabetes mellitus, in terms of a higher risk of diabetes mellitus later on in life. So this is data from the diabetes prevention program, looking at subjects with a past history of gestational diabetes and comparing them to women without a history of gestational diabetes. Just over a period of 3 years, you find a higher cumulative incidence of diabetes in those who had that history of GDM, almost a 70% higher risk. In fact, it's hugely dependent on BMI. So if you have a BMI about 30 and a history of gestational diabetes mellitus, your risk of developing type 2 diabetes over the next 10 years might be as high as 7 in 10. So almost a 70% risk. So what about lifestyle and metformin? So this is again data from the diabetes prevention program, looking at the subset of women and women with the history of GDM and comparing to those without a history of GDM. So this is subjecting them to metformin and intensive lifestyle modification aimed at about 5 to 10% weight loss. And you notice that over the period of the study, this is the group with the history of GDM. You have equal efficacy of metformin and intensive lifestyle intervention. So almost a 50% reduction in the incidence of diabetes over the course of 3 years. So yes, they're at a higher risk of progressing to diabetes. But when you use intensive lifestyle intervention, just a weight loss of about 5 to 10%, you have a huge reduction in the risk of progression to diabetes. The number needed to treat in this study was about 5. So only 5 women would need it to be subjected to the intervention to prevent 1 case of diabetes. So that's more effective than any of the medications that we know of. So, all right. So where are the potential areas where we could intervene to prevent this cycle of obesity? Now, one is the pre-pregnancy period, because we know that higher maternal BMI before pregnancy puts both the mother and the infant at risk of adverse outcomes. The other one would be the gestational period itself in terms of gestational weight gain. So we know that higher the gestational weight gain, higher the risk of large for gestational age and risk of metabolic disease later on in life. And the third area would be the postpartum period, especially the postpartum weight retention. So if we can address postpartum weight retention, help them get back to their pre-pregnancy weight, and that would be a huge area of interest. Let's shift gears and talk about adipose tissue and how it might play a role. One is, with obesity, there is adipose tissue expansion, and the adipose tissue itself can do 2 things. One, it can multiply in number to take in the extra load, or it can get larger. Okay? It turns out that if you can increase the number of adipocytes and store the excess energy, you can continue to remain insulin sensitive and free of metabolic disease, at least relatively. But if you continue to increase your adipose tissue size, you actually cause more inflammation, and that could lead to the risk of cardiometabolic disease. So you can look at this in terms of adipose tissue size, the adipose cell size, and if you have the ability to proliferate your adipocytes, you're in better metabolic health. Now, here is again the positive energy balance. And your adipose tissue is much needed in terms of it acts as a buffer to store this excess energy, because we know about the states in which this is deficient. For example, lipodystrophy, where you have literally no adipose tissue, and these people are at very high risk of metabolic disease and diabetes and so on. So again here, if you can proliferate them, you're doing okay metabolically, but if you're able to just only enlarge your adipose tissue stores, you do spill over, and there's ectopic deposition of fat, and leading to insulin resistance and an inflammatory milieu and so on. And the same thing with the partition of the adipocyte. For example, subcutaneous adipose tissue versus visceral adipose tissue. This is the one that might spill over into the metabolic organs such as the liver, the skeletal muscle, the pancreas, the heart, and so on, and create adverse outcomes. So I want to introduce this concept of personal fat threshold. So even though obesity is a risk factor for type 2 diabetes, not everybody who presents with type 2 diabetes has a BMI above 30. A large proportion might have a BMI lesser than 30, hugely dependent on ethnicity, especially in Asians and so on. So this is data from the United Kingdom prospective diabetes study. This is individuals with type 2 diabetes early in their course, and the mean BMI in that study was about 27. Okay? Now the concept is, when you look at groups of individuals, okay, and track them over time and see when they develop diabetes, it seems that their BMI curves move to the right to develop diabetes. Okay, this is not surprising. But when you look at an individual level, okay, each individual seems to have a personal fat threshold above which their risk of metabolic disease increases. For example, this is 3 individuals looking at moving their weight or BMI curve to the right, leading to the diagnosis of diabetes. And if you can institute lifestyle changes in them and move their weight and BMI slightly to the left, okay, we're talking about a 5 to 10% weight loss. One, you can improve your diabetes. But if it's a larger degree of weight loss, we're talking about 10 to 15%, you can lead to the resolution of diabetes. So I think that's important to use when counseling patients. For example, it doesn't need to be achievement of a normal BMI. Okay, it can be just moving towards a normal BMI, or 5 to 10 to 10 to 15% weight loss that can lead to huge metabolic benefits. All right, so we've talked about insulin resistance and we've talked about the risk of diabetes. Now, what can we do much ahead of time to, one, identify it and institute intervention? So we have these classes of pre-diabetes, or somebody who would be at very high risk of developing diabetes over the next few years. So one would be by fasting plasma glucose, which is between 100 to 125. And you could do an oral glucose tolerance test, which is your 2-hour OGTT with 75 grams. And if you have a glucose between 140 to 199, that would be a diagnosis of pre-diabetes. Somebody who is at very high risk of developing diabetes over the coming years. Again, with an A1C of 5.7 to 6.4% would be a diagnosis of pre-diabetes. Okay? But the question is, are we already late in identifying insulin resistance if we go by only this criteria? So this is something called the homeostatic model assessment, which is looking at fasting insulin and fasting glucose levels, okay? Because if you go just by the glucose level, you might be late in the diagnosis. But if you use a combination or a product of the insulin and the glucose, both being fasting, then you can get an estimate of insulin resistance much ahead of time. And this is a study that followed patients over a period of about 10 years. This is doing the oral glucose tolerance test, but looking at what the predictability of incidence of diabetes is based on the insulin pattern. So this is not the glucose pattern. This is looking at what happens to the serum insulin at different time points during an oral glucose tolerance test. And you find that when you have pattern 4 or 5, which is a delayed peak in the insulin, and also incremental or higher insulin responses to the oral glucose load, what happens is you're nearly at a 40 to 50% risk of diabetes over the next 10 years. So even among those with insulin resistance, okay, depending on what degree of hyperinsulinemia you have in response to an OGTT, you can predict somebody at a much higher risk of developing diabetes. And this is much, much before the diagnosis of diabetes, because insulin resistance clearly precedes one pre-diabetes and definitely diabetes, and also cardiovascular disease, and we'll talk about that. So let's again shift gears a little bit and talk about brown adipose tissue. Okay, so all of us know adipose tissue, and this is white adipose tissue, the usual locations. But if you've noticed small infants, when they get out of their shower, they do not shiver. Okay, this is, I don't know if you noticed that or not, as opposed to us who might have a cold shower and then end up shivering. This is because of the proportion of the brown adipose tissue that they have, which is again has the ability to cause thermogenesis or generate heat when exposed to cold. Okay, this declines as you become an adult, and further so when you age. Okay, so these are the typical locations of brown adipose tissue: the region of the neck, the supraclavicular area, the paravertebral area, and so on. And there's also something called the beige adipose tissue, which is essentially has characteristics between the white adipose tissue and the brown adipose tissue. In simple terms, brown adipose tissue, a better metabolic health, okay, as opposed to white adipose tissue, depending on the location and the inflammation, might be at risk of cardiometabolic disease. Okay. So again, exposure to cold activates your sympathetic nervous system and activates brown adipose tissue such that you increase energy expenditure. And this is, again, sympathetic nervous system activation. This is norepinephrine, again acting on your mitochondria. And instead of producing ATP, you have the upregulation of uncoupling proteins, which leads to energy expenditure in the form of heat and not really ATP generation. So again, the most efficient way to activate brown adipose tissue is exposure to cold. And one of the mechanisms is exercise. And there are several other hormones and molecules being studied to see what could efficiently activate brown adipose tissue to increase energy expenditure with the least side effects. Okay. So this is a study looking at what happens if you have cold exposure. This is acute cold exposure over a period of 2 hours. Notice that it's a temperature of 65 degrees Fahrenheit. So these were subjects that wore a cold suit. Okay, it's essentially a suit with water that circulates at a temperature of 65 degrees Fahrenheit. And this is a PET scan imaging. So these are the areas of brown adipose tissue. So this is again the neck, the supraclavicular, the paravertebral areas, and so on. And when you notice on exposure to cold, there's increased uptake in these areas. For example, these are the brown adipose tissue areas that show increased uptake of glucose. Okay. Now, after cold exposure, okay, these subjects were put through this cold exposure or cold body suits for a period of about 2 hours. And then they had something called the glucose clamps or hyperinsulinemic glucose clamps to study insulin sensitivity and insulin resistance. You notice that after that brief period of cold exposure, they increase their insulin sensitivity. Okay? So higher insulin sensitivity is good, is a good thing metabolically. In the absence of changing insulin release, so what about the association of BMI with the brown adipose tissue activity? So when you look at populations and subject them to a PET scan to look at brown adipose tissue activity and look at the relationship to BMI, lower the BMI, higher the activity of the brown adipose tissue. But as you increase BMI, there is lower activity of brown adipose tissue. So this is again a study looking at cold exposure and brown adipose tissue and looking at energy expenditure. So these subjects were followed for a period of 6 weeks and exposed to cold for about 2 hours every day. This is about 65 degrees Fahrenheit. All of them had low activity of brown adipose tissue at baseline. So it was a higher risk group. But then you find that that degree of exposure over a period of 6 weeks increased their activity of brown adipose tissue. But more importantly, when you looked at energy expenditure by way of indirect calorimetry, so on exposure to cold, they increased their energy expenditure over a period of 6 weeks, as opposed to the control group which were not exposed to cold. And if you look at body fat mass, there was a small decline in the body fat mass, about 0.7 kilograms, but still enough to increase energy expenditure. So what about how common is insulin resistance in the population that we see maybe in the primary care clinics or in the cardiovascular setting? Okay. So this is a primary care population with hypertension and dyslipidemia, and looking at whether they have pre-diabetes or diabetes. It turns out nearly 40% of this population has either diabetes or pre-diabetes. Okay? And what's the best test to screen to detect that would be an oral glucose tolerance test. But a fasting plasma glucose did good enough in that it could detect about 80% of this population. But if you combine that with the 2-hour postprandial glucose, which is in the setting of an OGTT, you were able to detect about 92% of the population. Okay. What about in those with coronary artery disease? We know that insulin resistance plays a huge role or a risk factor in the development of coronary artery disease. Now, how many of them have pre-diabetes or diabetes? It turns out nearly 90% or 9 in 10 people with CAD have either pre-diabetes or diabetes. Okay, nearly only about 10% were normal by OGTT. So what about coronary artery calcium scoring and comparing that to Framingham risk score categories? So you find that this is the Framingham risk score categories. This gives you the risk of CAD or cardiovascular disease over a period of 10 years. And this is the highest risk category, which is about 20% risk. And this is the lowest risk category, which is 0 to 2.5% risk. And if you do coronary artery calcium scores, which is by CT scans, and look at the burden of coronary artery calcium, one, there's an increased prevalence and also severity of coronary artery calcium across the risk stratification of Framingham risk score. But more importantly, does it help us reclassify these individuals? For example, it turns out that in the lowest risk group, it's not much useful. But in the intermediate risk group, we're talking about risk group between 7.5% to 20% risk over the next 10 years. You find that the number needed to screen to detect underlying significant burden of coronary artery calcium was only about 4 to 7. Okay, 4 in the highest risk and 7 in the lowest risk, between 7.5 to 10%. So the question I'm getting at is, one, are there ways we can detect diabetes much ahead of time, which is by way of detecting insulin resistance, and can we identify atherosclerotic cardiovascular disease ahead of time and intervene to prevent progression? Okay. So if you look at increasing age, and mortality. You have a higher risk of mortality. Okay, this is not surprising. But again, even among those strata of age, when you look at the coronary artery calcium burden, and with an increasing coronary artery calcium score, you find a much higher risk in mortality. So above the age of 70 in this study, which is the MESA study, nearly 50% had a coronary artery calcium score that was 0. Okay? So that is very good. That means a lower risk of mortality. But if somebody had, and this was a small number of individuals who had this, but above 1,000 coronary artery calcium score, their risk of mortality was very, very high, just over the small period of the study. So let's talk about fasting. Okay, so what do we know about fasting? In general, all the studies in animals, in bacteria, yeast, worms, and mice show that with caloric restriction, you have a prolonged lifespan. Okay? And what are the underlying mechanisms? Again, at multiple different levels, at the level of the brain, the heart, at the level of insulin resistance, at the level of the adipose tissue, and so on. One, increasing parasympathetic tone, so reducing your heart rate, reducing your blood pressure, but also increasing insulin sensitivity such that you have better metabolic health at the level of the liver, at the level of the muscle, and so on. At the level of the brain, a potential for neurogenesis and increased network plasticity. So maybe potentially a lower risk of degenerative disease and so on. So what happens to substrate when humans fast? Okay. So this is subjects followed over a period of 40 days fasting, just a plain water fast. And you find that the greatest increase in metabolite is beta hydroxybutyrate, which is you stop or exhaust your carbohydrate sources quickly. Okay. That's essentially your glycogen stores in the liver. And then you switch to fat metabolism, okay, which is adipose tissue stores, breaking them down to form ketone bodies or ketogenesis. And that's what predominantly happens in your circulation. If you look at brain substrate uptake, in a postprandial state, your brain is relying upon glucose as its source of energy. But in a fasted state, or you're essentially relying on ketone bodies. So the brain, the predominant source of fuel for the brain in a fasted state, once you make that switch, is beta hydroxybutyrate or a ketone body. Now, what about the role of fasting in cancer prevention or cancer treatment? Okay, what could the underlying mechanisms be? There have been a small few pilot studies looking at the combination of fasting and chemotherapy. So subjects who went through chemotherapy were asked to fast, and they looked at outcomes over time. Okay, one, it turns out in small studies that they tolerated their chemotherapy better. We're talking mostly about breast cancer studies. And two, their chemotherapy was more effective. Okay? Now, longer studies are ongoing to look at this effect, but what might the underlying mechanisms be? So if you subject humans to short-term starvation, essentially you have decreased glucose and decreased insulin and IGF-1. Okay? That might prompt cellular mechanisms to develop that protect against stress. And normal cells have the ability to do this, which is, the ability to sustain through a period of fasting. Whereas tumor cells, when you subject them to starvation, do not have the cellular machinery to adapt to this stress, okay, which might be, chemotherapy and so on, and get differentially sensitized, as opposed to differentially resistant for the normal cells. So you might postulate that you might increase the effectiveness of chemotherapy, and two, decrease the side effects, which I think, from very small studies is what's been shown. But again, larger trials are ongoing. Now, what about the effect of metformin? Again, we talked about some of the pathways earlier on, mechanistic target of rapamycin and so on. And you find that metformin, through its activation of something called AMP kinase, downregulates mTOR and might suppress cell growth and promote longevity, and again have a role in cancer prevention and so on. So what about the fasting mimicking diet? So when we talk about fasting, I think we need to define what fasting is. Okay, fasting essentially is the absence of caloric intake, right? So there are multiple ways to do fasting. You might have heard of different terminologies. One might be a prolonged fast, which is typically we're talking about a fast longer than 2 days. Okay. One might be intermittent fasting, which is again you're alternating periods of feeding with periods of fasting. A fasting mimicking diet in this study was a hypocaloric diet for 5 days of the month, and essentially they changed the proportion of macronutrients that would mimic fasting. Okay, so essentially they had a low protein intake, about a 10% macronutrient composition, and the remaining diet was equally split between carbohydrates and unsaturated fat. So they had complex carbohydrates, about 45% of their diet, and the remaining was made up by unsaturated fat, about 45% of their diet. So these subjects were compared to control over a period of 3 months. So fasting mimicking diet for 5 days of the month for 3 straight months. Okay. So when you looked at body weight, they had the fasting mimicking diet had a decline in their body weight, a decline in their BMI, a decline in their adiposity, lower IGF-1 levels, lower blood pressure, so metabolic benefit. Okay. Now what about if you stratified individuals based on underlying risk? You find that greater the BMI, greater the weight benefit, higher the blood pressure, greater the blood pressure lowering benefit, higher the baseline IGF-1, again greater the lowering in IGF-1 with the fasting mimicking diet, and the same with hyperglycemia. Higher the glucose levels, greater the benefit in terms of lowering. And higher the marker of inflammation, which is, we can use CRP as a marker of vascular inflammation, greater the reduction. Okay. So in this study, the hypocaloric regimen that was used was 1100 kilocalories on the first day and 800 kilocalories for the remaining 4 days, or the 5 total days in that per month. And they actually provided their subjects with meals, which is again very hard to do and very hard to achieve that degree of caloric reduction. Okay. Now what about the role of the circadian rhythm? Okay. So just like you have the light-dark cycle or sleep-wake cycle, you also have a feeding and fasting cycle that might be closely tied to the risk of metabolic disease and actually cardiometabolic disease. Okay? Here, again, just like light controls your sleep-wake cycle, it turns out that there are peripheral clocks in the liver and in the GI tract and so on that actually respond to nutrients and cycle in a rhythmic fashion or in a 24-hour rhythmic fashion, and are closely linked to your central circadian clocks, such that a disruption of your peripheral circadian clocks might also cause central circadian disruption and so on. Okay. Now let's talk about, at least in animal studies, what do we know about circadian disruption? Okay. So if you subject mice to a high-fat diet and they feed all day and all night, you find that they are at risk of diet-induced obesity. But if you subject the same mice to a high-fat diet but keep it to the nighttime, so nighttime is normal circadian rhythm for mice, that's when they feed and are most active, as opposed to the daytime when they're not. So it's an inverted rhythm with humans, but you find that you protect them from the effects of diet-induced obesity. This is no change in caloric intake or the macronutrient composition of the diet, but only a change in the time of feeding. Okay. Now, what do we know about the effects on other organ systems? Essentially, time-restricted feeding. So, by time-restricted feeding, what we mean is you're restricting your feeding, one, to the day, to specified time periods during the day, and going the rest of the day without eating, okay, or essentially fasting. And at least from animal studies, you find several different organ systems benefit. From human studies, at least there seems to be a benefit for a decreased risk of breast cancer, and also improving sleep quality and so on. Now, what about our normal eating patterns, okay, or abnormal eating patterns, if you may call it? When you study individuals as to what time they start eating and what time they stop eating, when you subject them, this was a study that used food photography, which is essentially every time they ate, they took photographs of their food, and that documented essentially what time you started to eat and what time you stopped eating and what was the composition and so on. You find that a very large proportion of the study population ate for more than 15 hours of the day. Now that might sound shocking, but that's essentially starting to eat at 8 o'clock and then going on till 11 o'clock, okay, at night. So more than 50% of the study population did that. And on the weekends, it got more and more prolonged and more delayed, such that your eating period spilled into late evening and also at night. Okay? Now what about when you subject these individuals with an abnormal eating pattern to time-restricted feeding? Essentially eating during the day, trying and restricting their eating period to 10 to 12 hours during the daytime. Okay? You found that over a 16-week period, they had weight loss, reported improved sleep, and also reported improved quality of life. Okay. So there's the potential for metabolic benefit with just changing the time duration during which eating happens. Okay. What about its role in subjects with type 2 diabetes? So this is again a very small study looking at 3 phases. Same subjects were subjected to a 2-week intervention period. And prior to that was a 2-week run-in period and a 2-week follow-up period after that. Okay? Essentially, they did time-restricted feeding, which is they were asked to fast for about 18 to 20 hours of the day and eat within a 6-hour period. But they could only get to a fasting duration of about 16 hours. And ate within a period of about 8 hours. And they found that over the time period of the study, which is again very small, just over a period of 2 weeks, they demonstrated weight loss, a decline in BMI that was significant, and also an improvement in their glycemia. That means they had better glycemia 1 fasting and also postprandial glycemia. And this is again a study in subjects with type 2 diabetes, looking at what the metabolic benefits of time-restricted feeding might be. Okay, they subjected. There are 2 groups here. One is the group that ate 2 meals a day, and the other is the group that ate 6 meals a day. Okay, the group that ate 2 meals a day were asked to restrict their time period of eating to about 6 to 10 hours. Okay, so 6 to 10 hour time period of eating and 2 meals. And they were followed for a period of 3 months. You find that they have weight loss, and when they have MRI to look at their hepatic fat content, there was a decline in their hepatic fat content. They improved their fasting glucose, and there was not a significant change in A1C, but still they improved their fasting C-peptide, which again is a marker of insulin production, and they improved their insulin sensitivity. And all these things are very good metabolically. Now, before I end, I want to just touch upon, we talked about altered gut microbiome in the beginning, but then there's just so much data coming out, and I think we are still yet to learn what role the gut microbiome plays, and how, more importantly, how we can modulate it to lead to better health and so on. So just in summary, I think we touched upon time-restricted feeding. We talked about the role of the circadian rhythm. Just like there's a day and night cycle, or sleep and awake cycle, there's also a feeding and fasting cycle that's tightly regulated. And by syncing those cycles, you might have a metabolic benefit. We talked about fasting, cold thermogenesis, which is again the brown adipose tissue, the potential role of a coronary calcium score, and what's the role of early diagnosis of the insulin resistance, and how the period around pregnancy is so important in addressing weight before, during, and after pregnancy might help prevent this cycle of ongoing obesity, and also the important role of breastfeeding. Some tips from my rule book, again, eat right, sleep tight, chill out, and cycle fast forward, okay? Now, eat right, again, what I'm getting at is as whole and as unprocessed foods as possible. Sleep tight, meaning, sleep is important. I think, many of us in training and in medicine, we neglect the importance of sleep. And it's important to have defined time periods and stick to that. Chill out, again, I talked briefly about cold thermogenesis, but also it could mean to refer stress. So if we can find ways to reduce the stress burden, I think we have improved metabolic outcomes. Cycle fast forward, again, the important role of exercise, but also the importance of circadian rhythm, okay, respecting nature in terms of there's a day and there's night. So there needs to be an eating and not eating period, and not eating across the day and night. I think very simple things that can be done that would go a long way in prevention of metabolic disease. So again, the role of prevention cannot be overemphasized. And thank you. I'm happy to take any questions. Questions, comments?
I have a couple of naive questions. Based on two of your slides, people can live for 40 days with just water. You said 40 days fasting? Is that?
Depending on the adipose tissue stores. So the greater the adipose tissue stores, the longer period of fasting you can sustain. But if you're somebody who's starting off very lean and doesn't have a lot of adipose tissue stores, it's going to be hard or not possible. There's a Minnesota study, I forget, was it in the 1950s that it was done that humans were subjected to fasting for a period of 6 months. Yeah. The longest known human fast that was medically supervised is beyond 1 year. I think it's some 380 days or something.
Just water.
I'm sorry?
Was this drinking water?
Water and I think multivitamins or something. No, that is not applicable at a population level. That's why I'm restricting to time-restricted feeding, which is alternating your feeding and fasting intervals within the 24-hour periods.
I'm doing other subspecialties.
Go ahead.
In relation to the breastfeeding, do you know if it's strictly direct breastfeeding or if it applies to pumped milk? And that the babies can self-regulate their intake if there's direct breastfeeding, but if you're pumping and giving by bottle, then they're still being given a certain volume.
Okay. I do not know. I mean, I think this study did not ask that specific question. This is more with respect to the breast milk itself and adequate breastfeeding compared to inadequate, the time duration.
Sure.
Yeah. But that's a good point. I don't know what other studies show in terms of comparing those two groups that you brought up.
I have another naive question.
Yes.
But based on the slides, do you burn more calories if it's cold? Like if you're exercising outside and it's cold? Or?
You do, actually. So the role of the brown adipose tissue content is very little. It's only about 50 grams on average, okay? But you find that even in subjects who do not have a lot of brown adipose tissue, subject them to some degree of cold, which is not too cold. 65 Fahrenheit is, most of us would say is okay. They actually burn more in terms of energy expenditure. So they increase their cold-induced thermogenesis, okay? As to how significant of a change that is, I think depends on a lot of factors. But on average, brown adipose tissue can contribute to, I think from studies, between 100 to around 350 kcal energy expenditure per day, which can be a significant amount. So maybe in winters, maybe we can make an argument of saving energy, not keeping the temperature up to 70 or 80 Fahrenheit, and maybe in increments turning it down by 2 to 5 Fahrenheit, Or maybe on a cold day when it's 50 or 60 outside, maybe carry the jacket in your hand and not wear it,
There was a study of folks going down for the Antarctic winter and spending several months in the Antarctic winter, and their energy expenditure soars.
Yeah.
Maybe even 1,000 kilocalories a day.
And athletes are focusing on one, training in the fasted state, but also training in the cold to improve performance. You know, you'll find this among athletes commonly. Like earlier, I think there was all this focus on load up on carbs, you know, make sure you load up on calories before you run marathons. And now the concept is moving towards enhanced exercise performance in a fasted state. In fact, you know, they've looked at cognitive outcomes in a fasted state. You have a sharper mind, you do better on memory tasks, and you perform better on exercise and training and so on. So a lot to be still learned, and as to who it can be applied to and who not to, but I think it holds so much potential. I'm just so frustrated writing prescriptions and doing refills that even before, nutrition advice used to be so hard. Talk about macronutrient composition, talk about calories and counting calories. And I used to get frustrated, my patients used to get frustrated. And now I ask them, when do you start eating? When do you stop eating? Can we narrow the two? Kind of bring them close together. I think it's worked very well for my patients, both with and without diabetes, decline in insulin requirements. That's one other thing you have to be cautious. So if you're talking to your patients with type 2 diabetes or diabetes in general about intermittent fasting or time-restricted feeding, they will decrease their insulin requirements. So you have to anticipate it and reduce their medication burden, not result in hypoglycemia. Somebody else had a question?
I was going to ask, is there any way to make people feel less terrible when they're fasting? Because I don't think I'd be sharp, personally.
There is definitely an adaptation phase. So I would say, don't go today and do a 40-hour fast. Okay, definitely not. Okay, I would start slow and move slowly. Okay, every time just ask yourself, when do you start eating? When do you stop eating? Can that be moved by 30-minute increments closer to each other? That's a simple step. The other important thing is people forget about keeping well hydrated. Most of which you feel terrible is because of dehydration and you're not keeping up with your fluid intake. So that can definitely be addressed. And a lot of different things can happen even in the fasting state, okay? Some of my patients like to sip on green tea, some of them like to sip on coffee, so different things that are non-caloric but still get them through the day in the fasting period. One other thing I'll say is the sensation of hunger, as you might well know, is very imprecise, okay? It doesn't mean that when you're feeling hungry, you're actually hungry or your body is seeking food, okay? When you study people who fast for 15 days or 30 days, you find that just after the first few bumps, they actually do not have the sensation of hunger. That the ketogenesis that's happening actually suppresses hunger and suppresses appetite. So there's definitely an adaptation phase. Always start slow and move slowly. Do not attempt any prolonged fast without medical supervision. So. And if you think about it, how many of us, mostly through the sleeping period, we are asleep. We're not setting an alarm every 2 hours and waking up to feed so that we don't pass out when we get up in the morning. No, you're going to bed and you're not awake until the next morning. So that is fasting. All we're talking about is prolonging that duration of fasting to make it in sync with your circadian rhythm. So.
Well, is it a myth that we have had that you need to eat breakfast?
I was hoping somebody wouldn't ask the breakfast versus lunch versus dinner question, but nutrition studies are extremely hard to do. Like, how do you delineate what's the most important meal of the day? But there might be an interest in some certain food companies to propagate that breakfast is the most important meal of the day.
General Mills.
So again, in general, I think there's more studies to be done and more to be known. But if you can eat your meals during the day, and hopefully in the earlier part of the day, I think you do better as opposed to late in the evening or at night. So if breakfast and lunch does it for you, I think that's good enough. That's very good. Some of my patients do that. But the majority run into a practical problem like I do. Okay? You have families, you go back home, dinner seems to be the family meal. So how do you not do that? It's kind of a hard thing to ask. I think you can ask for it to be moved to an earlier. No parties after 7 o'clock, you know. So I think all of that is reasonable, even on a daily basis. I think we can ask, and it can be done more practical to keep it to maybe lunch and dinner. But again, it's just an opinion. So. All right. Any other questions? Thank you.